Good afternoon, everyone. Thank you for joining us. Today is actually our final in our series of our CEO CFO webinar topics for this current grant year. These are sponsored by our Flex funds. And so our Flex grant year is September 1 through August 31. So August is kind of really our wrap up month. And so thinking ahead, September 1 is our Flex New Year. And so please let us know, what did you find most helpful, or what do you want to know more about, or emerging topics? And we can line up more webinars for our next grant year. Today, we are joined by Zach Bozer and Wade Gowan, both from Stroudwater, and they're going to be discussing managerial accounting in a critical access hospital. As usual, these are as informal, and so feel free, you can unmute yourselves, you can put something in the chat. I'll be watching the chat. But again, if you have any questions, comments, please feel free to share those. So with that said, I will turn it over. Thank you, guys.
Thank you very much, Laura. Good afternoon, everyone. It's great to be with you today and be presenting on the last of the webinar series. My name is Zach Bozer. I'm a senior consultant with Stroudwater and a former critical access hospital finance executive. I'm joined by my colleague, Wade Gowan, to present this material today. Wade will be our primary speaker. Wade is a former director of revenue for the largest health system in the state of Maine, where the two of us live. And Wade's also a CPA, so I thought Wade would be the perfect person to be presenting on a lot of these accounting slides for you today. Next slide, please, Wade. So for today's agenda, I will give a quick overview of kind of where management has been, over the past, couple of decades, and how things have changed, and kind of where best practices and where we think we're going in that direction in terms of management, as well as a quick primer on critical access hospital reimbursement. I will then turn it over to Wade for weighing some of the pros and cons of different types of budgets that we can perform for our hospital and go through the budgeting process. Next, he will speak a bit about financials and the importance of variance analysis and making sure that we are including all the different department managers within our hospital in that, both the budgeting and the variance analysis process to help foster ownership in each of their departments. And then lastly, we'll have plenty of time for questions if anybody has any at the end of the presentation. Next slide, please. So first, I will talk a little bit of an overview of kind of where we are, how we got here, and some of the things that have changed. So I really like to start with this chart here, where as we know, historically there has been significant amount of silos in healthcare, and particularly at a critical access hospital. And so this gives us kind of the longitudinal changes of how things have changed and kind of merged, and where do we think that we're going. So we've had really the quality side kind of in its own silo, historically, as well as early on revenue cycle and finance, and we all kind of operate in our own different silos, and we don't haven't talked as much as maybe we should. We're understanding today that we should, and seeing that quality has kind of continued down this path between different quality assurance programs, where we kind of start getting into the encouragement of greater coordination and communication, accountability within healthcare, moving along to quality improvement in the 90s. And then we've transitioned that to performance improvement over the last about 20 years or so. And then particularly the Affordable Care Act has helped move some of those things, and the importance of quality to healthcare and how things are changing there. And then, we had revenue cycle separate from finance as well, but along the way, those have kind of merged, where we're seeing joint revenue cycle and finance, committees, and we're measuring key performance indicators and, objectives and key results and others. And most critical access hospitals are currently kind of living in this revenue cycle and finance merged silo, as well as the quality department. And that makes sense that they've merged, because as a critical access hospital, knowing the way that revenue cycle affects payment, particularly thinking about the importance of the cost report and how payment and reimbursement are heavily dependent upon our cost report. It's kind of this natural merger of finance and revenue cycle. But we haven't quite gotten to that point yet of merging quality and finance and revenue cycle all together in a combined strategy focused, where we're, common silo, where we're putting together the quality and finance performance improvement. And, this is best practice today. And if we think about the way that payment is changing and how quality and savings, and these ACOs and everything combined together, and the importance of quality on payment in the future, that it's really important that we're all kind of coming together of with the different, quality and finance and revenue cycle leaders at our hospitals to come up with a common joint strategy to make sure that we're setting ourselves up, putting ourselves in the best position in the future to be successful. Next slide, please, Wade. And then, just quick touching on, the cost report, since we were talking about that and cost-based reimbursement, that as critical access hospitals, we're not a part of the IPPS and OPPS payment systems, which most short-term acute care hospitals are. And we receive cost-based reimbursement from Medicare, in certain states, Medicaid. And one of the things that's really important in a way to think about cost-based reimbursement and this concept of managerial accounting as well, is that this allows us to think a little bit differently about certain things such as capital initiatives that a PPS hospital doesn't really have, it's not afforded that opportunity. And so, if we as leaders are thinking about either, a facility replacement, or we're looking to purchase a new piece of equipment, maybe a CT scan, or look to implement a new EHR system, it's important that we think a little bit differently about what is the true cost of that capital purchase. So, for example, that if a critical access hospital were to spend $1 million on an annual basis, on this capital improvement, whatever it happens to be, that we're going to be able to be reimbursed from cost-based payers on our capital cost and interest expense for this particular initiative. And so to say, using that example, that if we're 50% cost-based, that our true cost as we're thinking about this really isn't $1 million, maybe it is upfront, but we're going to be getting a significant piece, 500,000 essentially back on our cost report in reimbursement, through the pieces of allowable cost of depreciation and interest expense. And this is something that's very different for a PPS hospital, which they're not afforded this opportunity. So it's really important that as we think about how we are managing our revenues and expenses within our hospital and looking to do new capital initiatives, in this example, that we're taking those things into account. I was recently working with a system that had a critical access hospital in the system, and they were looking at, do we ride out the new EHR system or the current EHR system for a few more years, or do we bite the bullet and, spend the $1 million to bring the CA onto the system platform? And the initial cost was, prohibitive, looking at it from the system level and working with some of the system folks, but then explaining really this concept to them is that, hey, this CA is 40% cost based. So really over the term of, the loan and the life of the asset, we're going to increase the reimbursement that we receive as a result of taking on, this new expense. And really we're getting this new EHR system about 40% off. And explaining that concept to them kind of changed the timeline that they were looking at. And it got, this critical access hospital on that new system earlier than they would have initially from, just thinking about it in terms of the system perspective. And that allowed them to get onto this new platform, and obviously being able to jump on the system platform and having the interoperability was a major benefit for both the system and the critical access hospital. So it's something really important to consider, as you're going through additional capital changes and looking to manage your hospital. Next slide, please. And Wade, this is where I will turn it over to you.
Fantastic. Thank you, Zach. And it's a pleasure to be here with you all today. I'm glad to be on this presentation. As Zach mentioned before, I have a CPA background and a reimbursement revenue cycle background. And so when we're talking about managerial accounting, right, that's something that I actually find a lot of enjoyment in, even though for most it can be a bit of a challenge to make it through. So I find all this really interesting, and I'm excited to talk more about it today with you all and hopefully get feedback from you all on best practices in your facilities. So we're going to jump into the budgeting process now. And before jumping into the types of budgets and the intent behind them, we just want to lay the groundwork. This might be common sense to a lot of those on the call, but when we're talking about a budget, right, we're looking at the income statement, balance sheet, statement of cash flows for an upcoming period of time. When we're thinking about revenues and expenses specifically, because our income statement drives a lot of the numbers. Just income can be various things. It can be your patient service revenue. It can be 340B revenue, what would fall under what would be considered other operating income. You have dietary cafeteria sales. I'm having trouble talking today. And then on the expense side, you've got everything from salaries and wages to benefits. Again, just laying out the examples of what those are, expenses being what's incurred in terms of a cost, and then revenue being the income that's earned through the provision of your business services for the hospital. The point I do want to focus on and emphasize in this slide is that a lot of CAUs that we work with have, I would say, a large focus on expense management and sometimes even expense reduction. And I would argue maybe a disproportionately high focus on expense management and reduction. It's interesting, I just experienced this chatting with a client the other day where there was a key member of the leadership team that was so focused on cutting costs and mitigating additional expenses that it started to create tension within the organization, specifically amongst key leadership roles. And I think what's really important for critical access hospitals to realize and to internalize is that the expense management piece, when we're talking about budgeting, and as we talk about later, the financial statements and variance analyses, expenses are only one piece of the equation. And as Zach already talked about a little bit, when we have a high cost-based payer mix through Medicare and sometimes our Medicaid payers, really expense cutting is not the key in terms of overall financial success for the organization. It is a key piece of it, but it is not the one and only thing that we need to focus on. And you can only play the cost-cutting game up to a certain point before you start creating internal tensions and even in some really severe cases, reduce patient care. So I do want to emphasize that because what we like to focus on and what we often recommend is to focus more on that revenue growth. And we'll talk about that later, but this comes from really developing our current services. So marketing those services within the community and to other area providers, as well as thinking of ways that we can offer additional services within our community, especially because as critical access hospitals, we play such an important role in the community that we're involved in. And we want to make sure that we're providing the best care to our patients and our community. And so that's generally how we see it, is we should be really looking for those revenue growth and service growth opportunities as opposed to focusing exclusively on expense management. From a budgeting perspective, when we're thinking about the different types of budgeting, there are a few different types. What we chose to do is include two of the most common that we see, the most common budgeting approaches, one being the incremental budget and the other being the zero-based budget. And so from an incremental budget perspective, this is what I have seen most commonly when interacting with hospitals of varying sizes and all throughout the rural communities that I've personally worked with. The incremental budget is a very common method of budgeting for a future period. And this involves using your prior year as a starting point and then making assumptions about where you would expect volumes and associated expenses to go. But the starting point is that prior year or the prior period. And so if we would say, consider budgeting for the upcoming year for a clinic, and we know that we hired a primary care physician at the tail end of our prior year, since that wouldn't be reflected in the prior year's actual performance, when you look at the income statement, you would then say, okay, we're using the prior year, but we understand that we added a primary care physician. So we're going to increase volume by X% because that's what we think is reasonable. Now, in contrast, the zero-based budget is where we start with the question of, what should we be expecting in terms of the hospital over the next year? And what is the justification for using these resources in the upcoming year? So you don't necessarily start with your prior year. You start with building the budget from scratch. And so it's a very different way to approach it. It's a time-intensive way to approach budgeting, but it also allows you to challenge if there are any assumptions baked into prior periods that might not be the most efficient, or if there are any opportunities for improvement, those could be better vetted out theoretically by a zero-based budget, because you don't have all that prior history that might be skewed a bit. And so they're all based on assumptions. When we talk about budgeting, we have to understand that they're both rooted in assumptions, and both are great. Sorry, I'm having trouble speaking. Both can be used to predict this upcoming year, and they're great tools to use. But it's important to understand that they are just that. They're assumptions, and you put them together for multiple different reasons. It might be required by the CEO or the board. You can also use these as an accountability tool, which we'll talk about a little bit later. And it can also be used to drive financial performance and monitor financial performance. So as we think about these two different types of budgeting methods, and again, there are multiple budgeting methods out there. These are the two most common that we found. We find that with an incremental budget, there are a few pros to it. It's pretty easy from the perspective of we've got the budgeting season that occurs prior to the upcoming fiscal year. It's relatively not easy, but it's simplistic in the sense of you start off with the prior year and then you add and bake in any assumptions for the upcoming year. It can be easier to manage. And in terms of the time commitment, though the budgeting process is a very consuming, it's a time-consuming exercise regardless of what method you use, it can be less time-consuming than a zero-based budget. As I mentioned before, though, the cons can be, it'll carry forward any inefficiencies, any potential inefficiencies that may have been included in prior years. It also makes an assumption that your operating performance is a good predictor of what will happen in the future. And even though you make some slight tweaks to that, it does start with that premise of this is a good starting point. And in some cases, it can lead to increased spending, just that you can meet prior year's budget, so you can justify it. And so it's also less responsive to market variation. So for instance, we just had an incredibly volatile period with COVID-19. So when we started using incremental based budgets, if you think about 2020, a lot of budgets were completely shot that year. And I remember that I was working at my prior facility back in 2020. And what we would do is model out reimbursement, we would model out net revenue. And it was interesting to see all of the unintended consequences of COVID and how that impacted the budget. So it was a pretty big task to try and figure out, okay, how do we explain this month to month? We're dealing with these unprecedented changes in volumes and revenues and expenses, and how do we account for all that? So again, with the incremental budget methodology, it can be challenging to respond to that market variation. Now, looking at the zero-based budget, it is better equipped to address some of that market variation. So theoretically, if there are major market events, major shifts happening, you can better adjust the budget to plan for those. It can lead to innovation. Again, this is all about getting our department managers and key leadership to question what has been going on in the past year and what should our expectations be for the upcoming year. So it puts you in evaluation mode. And so in that sense, it gives you the opportunity to step back and look at things a little bit differently than if we're just using the prior year as the base. The cons to that is that it is very time consuming. As I mentioned before, it's pretty simplistic to use last year's financial performance as the baseline and then adjust from there. So, and it's understandable, it is quicker to take that incremental approach. And it also requires a much higher level of financial acumen for staff. If we're thinking about justifying all of our expenses and revenues, you really have to provide the education to the folks who are making those decisions and budgeting those out. And so it can be a challenge from that perspective, just to engage the non-financial staff around it. So again, they are both adequate tools. They're good tools to use for budgeting, but there are some pros and cons to each. When we think about it, again, as we think about the budget, we have the types of budgeting, but it's really important, and we believe it's very important to focus a lot on engaging our department managers in the budgeting process, no matter which budgeting method we choose to use as a hospital. And so we believe they fall into these three buckets. Increasing financial acumen. This is incredibly important. I know that when I'm on site with a client, or even in my prior role working in the hospital setting, it can be really challenging to help department managers understand some of the financial implications behind their departmental operations. If you were to go into an average hospital and talk to a department leader and say, can you tell me why cost-based reimbursement is important for your department and what are the implications there? It might be challenging for them to answer it, because we hear a lot that there's just not the high level understanding of the financial aspects of running the hospital. And I think it's critically important for us as leaders to really make sure that our staff are adequately trained and are provided education on this. If all of our department managers had a good handle on cost-based reimbursement, then that would be phenomenal from our hospital perspective, because they would understand the implications of some of the decision making. If they could understand contractual adjustments and charity care, and even the revenue cycle process, where healthcare is unique, where you have these very large contractual adjustments, in some cases applying to at a departmental level, that are impacting your P&Ls. And if we could educate our department managers on the implications of that, what that means, it could be really powerful in engaging them. Regarding the budgeting process, we believe very strongly that this is a key area where there shouldn't be simply a top-down, only the CFO doesn't go into a room, come up with a budget, and then tell everybody, well, this is how it is for the upcoming year. We believe it's very important to engage our department managers in that budgeting process to predict both expenses and revenues. As we talked about before, revenues being an important piece of this. It's not just about managing our expenses. We also need to look for that as well. And then in terms of revenue improvement, as we said before, this gets back to the idea that you can only cut costs so far. I love the quote there, you cannot cut your way to success from a cost perspective. One, because a lot of our costs are reimbursed. So any reduction in costs will have a less of an effect than, say, a PPS hospital, where it's truly you're paid a rate and you have a volume number, and it's really just about breaking even on that amount. You have this impact from being a CA, where with that cost-based reimbursement, you are protected slightly from that. And so I think there's no way to cut costs to success. You need to be focused on revenue improvement, and even putting enough information in the hands of our department managers to make those decisions. We really want them to be engaging in entrepreneurial thinking. What can I do to grow this department? What additional services could be offered in the community? How can we better market these services in the community? I think it's a fundamental shift in mentality, and we believe it's very important for the success of a critical access hospital. So moving on, we're just going to jump into the income statement and variance analysis. We'll talk a little bit about the financial statements as a whole, and then drill down to the income statement. And this is a description. I won't read everything here off the slide, but just gives an overview. You have your balance sheet, income statement, and cash flow. All of them play different roles in terms of the financial information that they provide. Balance sheet is that snapshot in time of the assets, liabilities, and equity. Your income statement shows, your volumes. What does that equate to in terms of revenues, any expenses, and it gives you that income figure. And then cash flows show you how well you're bringing cash into the organization, because as we're all very aware, just because we're generating revenues doesn't necessarily mean that automatically translates into cash flow. And that's where our revenue cycle operations comes into play. And so even though we need to have a good handle on all of the financial statements, we need to understand them. We want our department managers to understand them. We believe that the income statement is really what can be used to drive accountability and performance, because that will, because that's the most important in terms of really that accountability piece. You have your income, which includes, as we talked about before, that's your patient service revenue. It includes all the other operating income and non-operating income sources as well. Expenses, this can be a great way to help managers be accountable if you don't want to focus too much on cost cutting and expense management, but you can put in reasonable policies, procedures to help our department managers as they look to manage those expenses at a reasonable level. And then again, non-operating revenue, general and administrative allocation is an overlooked area. So that's an area that we want to be educating our department managers on, is the role that these other non-operating sources, whether that's revenue or expenses, the roles that they play and how that impacts our net income, first of all, and also how the rest of our financial statements look. It's critically important. This is really interesting. When working with clients, we utilize this flex monitoring team reporting. It's a really helpful tool, especially for critical access hospitals that are looking to get some sense of how they compare to other hospitals. It is a report that's generated on a consistent basis that utilizes publicly available data through the cost report to put together a whole bunch of key performance indicators and metrics. And it's utilized, put together through the University of Minnesota, North Carolina, and Southern Maine. And it tracks all these indicators over a few different domains. So for instance, it'll show you what the median is from a national and state perspective for total margin or cash flow margin. Same thing with liquidity. And so this is really a helpful tool that we utilize a lot, and we would recommend that other critical access hospitals utilize to get a sense of how they are performing, specifically at that state level and also at the national level. It's not the only way to do this, but we recommend that this be in a CA operator's toolbox so that way they can measure performance over time. And again, just some more metrics that are captured here. Again, I won't read all of them, but if you look up at the top, these blue boxes indicate the domains that these metrics fall within. And so we have a number of different domains here. Really good information for us to consider. Again, just following up, these are some of the additional ones. And what it also does is it allows us to think a little bit outside of the box. So if you have been measuring a certain metric for so long, there might be other metrics in there that might be more helpful in terms of understanding what the drivers of cost and revenue are. And I think this allows you to look a little bit outside of that box and figure out, are there other ways we could be tracking this? So yeah, we're going to talk a little bit more about performance metrics and engaging department managers. I guess I would open it up. If anybody has any thoughts about this, any other key performance metrics, I know it's a fairly informal setting here. I don't know if anybody had thoughts around certain metrics that they track or that they like to track, and specifically ones that can help bridge that gap between your financial staff and your clinical staff. I don't know if anybody had any thoughts on that. Perfect. We'll keep on going through here. Again, a huge piece of this, and what we believe is incredibly important, is engaging our department managers. We talked about the income statement and the importance of using that as a form of accountability for our department managers. There are some controllable aspects that department managers can focus on from the expense and revenue side. And so it's really important, though, that when we do that, when we provide this information, first we need to provide department managers with the information they need in order to take that entrepreneurial mindset that we discussed earlier. And so that involves increasing the financial acumen. So you holding these periodic trainings with hospital staff and department managers is incredibly important, especially if we're engaging staff who aren't necessarily in the weeds with this all the time. It's helpful to provide that continual training, so that way when we provide a department manager with a P&L, they're able to understand what it means and how it can be used in terms of accountability, in terms of performance, how they can okay, great. It looks like Josh Tucker mentioned that they use Medicare inpatient and swing bed utilization when setting up the budgets. That's a great metric. Thank you for contributing that. So again, lots of training. Training is essential. Revenue cycle, I think that this is a area in which we could all use additional training and education. I know I sure can. Really understanding even the difference between the P&L and the actual cash flows because of how the revenue cycle department operates. I think this is a great area to even focus on in terms of a performance improvement activity, depending upon how your tracking is and what your metrics are showing about the organization. Direct costs versus fully allocated costs. This is a big one. When we're thinking about adding services, when we're thinking about incremental services, really that difference between direct costs and fully allocated costs is so important. When we look at a cost report, for instance, and you look at the B series, right, you see fully allocated cost for a given department, whether that's lab or the OR. And if you're not careful, you can look at it and say, well, this department seems to not be making money or be making money. They're successful, not successful. without taking into consideration some of the variable costs in there that are really, that won't go away with any reduction in services. So I think that's the difference there when you're looking at fully allocated costs and you've got your direct costs, but being really careful about how we evaluate that when we're talking about different service lines and yeah, just thinking very carefully about that and making sure that we're tracking and that our department managers understand that difference. Because what might seem, if we're looking at a given service, what might seem really unprofitable, there may be some shades of gray there because we're including additional variable costs that really is not directly correlated with that specific services, and we would still have a variable cost if that service line were to be reduced or go away. And so I think understanding that is key. Again, giving our hospital staff the financial statements and metrics, helping explain what those mean. And then variance analysis, and this is what we recommend to clients when we talk with them a lot, is putting together a process by which you can hold managers accountable through variance reporting, usually with a preset or predetermined threshold. So if we're looking at expenses for a given month and we see that they're over budget by 10%, there would have to be a variance reporting requirement associated with that. It's a great tool. We often don't see that being applied in a consistent way from at a monthly perspective, at least. This is, again, another way to engage department managers. And what's really key is to understand that this is a great accountability tool, but it also needs to be coupled with the educational piece that we discussed earlier, making sure that we're equipping our department managers with the education and resources they need to be successful, engaging them in the budget process so that they understand what they're being held accountable for, and then doing the actual accountability work of something like variance analysis. And so, again, industry best practice, you provide the departmental P&Ls on a consistent basis. And these need to tie back to budgets so that they understand where they're at compared to budget. And then the best practice would be holding departments accountable to that overall performance. And so as we think about that, this is really a key area in terms of budgeting and financial. So with that, we have completed our slides for this particular presentation, but I do want to open it up, and I'd be really curious to hear more feedback on any best practices that any of you all on the call have. Are there any things that you've done in your facilities that have gone well? Are there any areas that we didn't cover in these slides that you feel are really important to financial management and managerial accounting? I guess I would open it up because I'd love to get discussion on that. Maybe some of the challenges involved in the budgeting process. I know that those can be, again, having come from a facility, budgeting out something like net revenue and third-party estimates can be a bit of a challenge. So I understand that part of it as well, but any thoughts, any feedback? All right. Well, with that, I just wanted to say again, thank you for the opportunity to share. And I know Zach and I appreciate the opportunity to be able to speak with you all. It's great to be in front of you and talk about a topic that I definitely appreciate quite a lot, managerial accounting. And with that, I'll open it up if there are any questions or Zach, I don't know if you had any other thoughts that you wanted to share or.
No, not particularly, Wade. Great job on going through the budgeting and the financial statement analysis. As you said, it's just really important to be focusing on those things and be thinking about, ways that as a critical access hospital that we're able to use them to our advantage and maximize, the resources that we do have. So again, just want to say thank you to everyone for joining the call today. Thank you, Laura, as well, for sponsoring us and having us today. And, if any questions do pop up in the meantime, feel free to reach out to Wade or myself. We will be providing the slides. Laura's recorded the presentation today, so you can go back and listen to it. But certainly, if there's anything that we can do to help, further and, bolster your hospital and your journey, please feel free to reach out. We'd be happy to have a conversation or trade some emails.
Absolutely.
Thank you both for the great presentation today, and thank you all for joining. If anyone does have any questions after this call, please feel free to reach out to me, or also if you're watching the recording and have any questions, please feel free to reach out to me. I can put you in touch. So thank you all, and everyone have a great day.
Thanks so much.
Thank you.
Bye, everyone.